Okay, we have our thank you for donating your shoulder to science. So we have, from a physician, diagnosed bicep tendonitis. What imaging have they done?
No imaging yet, just exam.
But yeah, palpation exams. Positive is ouchie, push here, ouch. And then starting point is rest and bracing. And don't discount that, by the way, for yourselves. You got something that bugs, getting something that can just get some support, whether it be a low back brace, a wrist brace, all of it, it's worth giving it a shot. You'd be surprised at what giving the body that little bit of extra support, what it might just start doing for itself. Now you've been doing that for a while. It's been...
This is third week.
Yeah, okay. And over, you said it's been up and down. Would you say it's tracking in any one direction?
Initially I did it for 2 weeks and it had improved, and then I went without the brace for a week, or the splint for a week, and it definitely got worse. And it was initially this head of the biceps, so that's what the long over there, and then it also became the short head of the bicep, where originally I didn't have the pain here, and then it kind of changed.
Let me do a quick pause, because this would be a good place for the anatomy. So let me just do a bit. So we were talking about bicep brachii in this case, the flex muscle when you're showing off, right? Now here, if I had amazing, look, it's even the right shoulder. So I'm trying to have x-ray vision related to this. Now this is the red stuff we're looking at. These are the rotator cuff muscles. So the acronym that gets used is SITS, S-I-T-S, for supraspinatus, superior of the spine, of the scapula, infraspinatus, so S-I. This little slip right here is supposed to be teres minor, and this is teres major, but only teres minor is considered a rotator cuff muscle. Functionally, I just think teres. I think about both of them. But teres minor, so S-I-T, and then underneath, between your scapula and your ribs, subscapularis. Functions of those: supraspinatus is an abductor, teres minor and major, adductors, subscapularis, internal rotator, infraspinatus, external rotator. Mostly what they're doing is holding and hugging this. So they're there at the deepest level, and then everything's getting stacked on top of this, right? We have them, we have all these crazy ligaments, there's some bursas usually hiding in here, a lot of stuff, and a lot of big bony projections and what have you. Like, there's this part of the scapula called the acromion, which that's the thing you can feel right here, that flat kind of plateau on the side of your shoulder, right here. The one you can't feel is this coracoid process, which is deep, right through here. So I'm not going to put her through that. We're going to try, because we had heard that deep palpation around here aggravated it. And that's the problem when you're dealing with a chronic inflammatory thing, is pushing on it and putting stressors onto that tissue directly may irritate it. So that's where tape could be something where you avoid massage of an area because you're worried that you think massage might agitate it, but you could use tape instead. Voila. Here, what this is supposed to be is the long head of the bicep. So bicep brachii splits, it connects as one down here at the elbow, but it splits up here. One head has to do this big swoopy over the humerus and then over onto the scapula this way. So it's a bit more lateral. The short head goes straight up onto that coracoid process. So does a muscle aptly called coracobrachialis. Coracobrachialis. My joke with you guys, not joke, but my teaching blah to you guys has been, outside of deltoid, the muscles of the anterior upper arm have B-R-A-C-H in their name. Coracobrachialis, brachialis, bicep brachii, brachii, brachialis, which is just an elbow flexor, and then brachioradialis, which is also an elbow flexor, but it attaches on the radius. But they all have a B-R-A-C-H in them. Yay. So initially, she's kind of pointing more lateral. Kept pointing more lateral. And that is kind of tracing the line of that tendon. The story makes sense, right? Mm-hmm. I believe you said palpation-wise, there was some poking here in the front. Mm-hmm. Now, I see you, is even your elbow flush here? Is that uncomfortable?
No.
So, it's not uncomfortable?
It's not uncomfortable. Okay. There's a little bit of like almost like a burning sensation right here.
Burning sensation. Now that ties in. Burning sensation tends to correlate with connective tissue. The concerning part can be, go ahead and lift up, back underneath. So, I have a smaller one. Yeah, let me change that out. Sorry, flippity flip, I'm sure that movement feels good. Putting the arm into kind of a sling position is usually the best place. Think like a recliner. You know, you're a little bit flexed, a little bit internally rotated. That's usually the more comfortable position for a myriad of shoulder issues. You're gonna work here. I'm a fan of putting the pillow under the elbow. Just protects the shoulder, keeps it from going to end range, then you don't have to worry. So now we have this like this. So we've also taken the tension off those shoulder flexors, all of them. So bicep brachii, coracobrachialis, all of that. We've created a little bit, we've shortened the stuff that's agitated. It'll be most angry when you try to lengthen it, or you try to fight through a lot of gravity and go through a big motion. So usually it's big motions, but especially reaching behind you, I'm guessing is guessing. I want the story to keep making sense. When it starts not making sense, then I pretend I know what I'm doing and get more careful with what I'm going to do. Now, you pointed here. Is there been anywhere else where you kind of felt?
No, it's just here and then in here.
Is the burning staying isolated here, or is it tracking?
It's that just the burning is just right here.
Yep. This is really good information. Have people show you if they can. I've seen this, and I've seen this. I've seen this and this. And that's just tracing. All right, that'll make sense in the story. So that makes me feel more comfortable. Now I have to, ideally with this, I'm like, well, at the very least, I want to tape over these structures. Worst case scenario, I do it wrong, and that tape is sitting there tugging on the superficial fascia and helping move any underlying inflammation. If I had a best practice, so let's say did the whole massage, ended in supine, and now I'm going to go to the most cautious and careful application I have in my hands-on practice, which is manual lymph drain. And all that's going to be is moving the skin to the point that it stops. Call that to bind. Take the skin to it stops, to bind, and then maybe give it a bit of a twist in a direction to bind again. But not through bind. I just nudge the skin. I hope I'm opening some of those little ducts, and then I give it a bit of a twist, and I hope I'm opening some different ducts. Manual lymph drain is almost always a move the skin toward. We start. If it's an inflamed area, maybe I can lymph drain that spot, but this works really good. The ball and socket joints are where the main nodes are. This would always be where you start. If it's arm edema and swelling, we start at the shoulder. If it's leg, we start at the hip and work our way down. Our direction will always be towards the torso. We're working distal to proximal, always. So here, just hands on. And I'm also feeling for assessment-wise, any heat. But this is a way of taking my assessment and making it feel like we're also doing massage, right? I want the person to feel like something's happening. So once I've palpated, I've gone, okay, I don't feel anything hot. It's a little sticky, which also can be an indicator. The story I create is if you feel something hot and sweaty, it means it's working too hard. It's like if a person runs in the room and they're hot and sweaty, I'm like, you've been working hard. So at least it's not hot and red. So it's not that acute, but it does feel sticky. So it's working hard, but at least it doesn't read as like crazy, angry, acute, right? So while there, now I just am doing something that I hope helps, but now I'm just gonna be doing some thinking. All right, biceps, what does that look like? Do I have an anatomy chart around so I can stare at it? Okay, I'm gonna look at that and try to remember the soup of information that happens when I read chapter 9. Who's on chapter 9? The later on group, yep. So, little bit. This is so gentle. Manual lymph drain, I want to try to demystify that one for the world, okay? It's not hard, it's not complex. So now we're here. Did a little bit of contact. You never know what just some contact and a little bit of movement of the superficial fluid might do. Now I'm gonna play with a little bit more. I'm worried a touch of aggravating it by asking her to do a lot of end range movements. We, at least in this case, have a scenario where she's gone to the doctor and been screened for anything more concerning. That they've said it's not likely a joint issue, it's not a nerve issue. I can defer in my mind that it's already been screened by somebody higher up in the food chain than me. And I just am going to be careful with asking for active movement here. Now I'm going to just try some passive movement, making sure. I want to make sure I can move her so I can get the tape on and it not hurt. I'm also going, how's rotation? Everything okay there?
Mm-hmm.
This way, probably better. Is there any kind of beginning?
No.
Great. That's pretty good. Now, coming out into elbow extension. Not too bad. Okay, I have this buffer of holding the shoulder in flexion. So you see what I wanted to confirm. I'm doing joint assessment. I figured out, yeah, rotators don't feel hung up. Elbow's doing okay. It's tight here. So if I was doing massage stuff, rather than going after the tendon, this is my thing with tendonitis, right? Remember, the tendon is the deep fascia cord that connects your muscle past the joint. We don't want to change the shape of the tendon, but we can change the shape of the muscle. So it hurts where the tendon is. I want to go away from that, find my anatomy book, or start to remember it and remember where the biggest part of the muscle tissue is. And if you just visualize the biceps when you see like those crazy bodybuilders where there's like a baseball right here, just right there. That's where the belly of a muscle means that's where the most amount of muscle tissue is. It's kind of the center of it, but it's where it has the most bulk. Now, if I'm gonna do something even extra with this, why not say to that tendon, I want you to have some breathing room. Poor tendon, you're being pulled on, it's ornery. Maybe if I compress the belly of bicep brachii and then try to nudge that muscle tissue towards the angry tendon, we'll just give it some breathing room. That shouldn't be ouchy.
No, that feels good.
Yay. Now, what could I start including? Maybe a little bit of joint movement. Small. We get to be delicate. That's the really nice thing about being in the massage world, right? We can take these therapies and we can just slow them down and be very gentle about them. And I can start with just really shortening it. I know, because I've stared at anatomy books for too long, that bicep brachii, when it shortens the most possible, it's a shoulder flexor. We have that with the pillow. It's an elbow flexor. I'm doing that now. And it even supinates the wrist. So I've shortened it as much as I possibly can. And now I'm going to try to just give it a little bit of a lengthen. I'm just holding a compression. I'm holding a compression with a direction that I hope makes the tendon happy. So I'm pushing towards the ouchie. Now I'm going to try to lengthen it. So I'm going to pronate and start to extend. And right under my pressure, I feel the skin tugging. I start to feel the skin start to get stretched under what I'm pushing on. Now we're phasing into connective tissue approaches. I can take the tissue and I can push to bind and then stop and then do it again. That's more lymphatic. If I take it to bind and then push through bind, we're doing something more connective tissue or myofascial. So connective tissue, myofascial release is about taking that superficial fascia to bind and then a little bit further, trying to stretch it. But it's much easier and it's more related to function if we do that instead of me just pushing. Why not take it to bind and then use the joint movement to go through bind? So that's what I use as my primary tool for myofascial release, is I compress the tissue and shorten it, and then I lengthen it. Isn't this similar to when we had you do the active movement stuff for muscle energy techniques? Where I have I use compression or not and have a person active movement, shorten, and then lengthen. Varieties of that are muscle energy techniques. Me just doing this passively, just this part of shortening it, pinning it, and then lengthening it. Anybody guess what that's called? Pin and stretch. If I had her actively lengthen, I passively shorten. I'm not going to have you do it, so don't do it. If I had her actively lengthen, that's called active release technique. Active release technique is active pin and stretch. Pin and stretch is passive active release technique. The positioning starts out the same, and then it's a question of just doing the additional lengthening. So I can think more about muscle tissue, or I can think about the connective tissue. Muscle tissue, connective tissue, fluid movement. A little bit of all of it is happening. It's just in my charting. Maybe where is my intention? Where's my mental intention? What does the client ask for? What do I think is more of the thing? But there's so much of this as I do it, I'm pulling off lymph drain, connective tissue work, and I'm changing the shape of a particular muscle, encouraging it to go from an overly shortened state to a more lengthened, relaxed state. And if we can get that to occur, if this muscle reduces in tension a little bit, maybe won't be pulling on that tendon so much. Yeah. Now I'm slowly gliding. Everything's still feeling all right? The more cautious look on the face. So that's where I know I've probably gone as far up in application because I was slowly gliding. We did the movement. Okay, getting a sense of
it's more the other.
Yeah. So I'm gonna be more comfortable here. Mm-hmm. Okay, we're just gonna keep it short. I'm doing stuff just ideally to help. So now I'm just gonna do more lymph, kind of connective tissue. It's the tough part ultimately is that you want to help so much. You have to try to, I know I have to try to hold myself back from trying to throw too many interventions. And here's the thing too, this is spot work right now. We haven't actually done the full body session. So it would be safer and probably already be feeling better if we had done the rest of the whole body and then came to this spot. In general, that's your best formula for a more acute, painful region. Work everything else, do the whole body, avoid it for the most part, and work on it at the very end. That's your best formula. So, still feeling okay? Mm-hmm. Okay. Here's where maybe that movement back and forth was part of the agitation. Now, this gets really boring to watch. And from an observational standpoint, but right now I'm stuck to the skin, and I'm gliding like a centimeter a minute. It gets slow. She can probably feel that I'm slowly tracking, but you probably can't see that my hand is actually moving. So that's myofascial release. It's gluing your hand to their skin and then putting it on tension and being as patient as you can tolerate. But the pressure is very light. You're not pushing down into the body, so you got to control that you're staying surface and trying to stretch the skin and not push too much down in. That's the nuance, is not letting yourself get lost, like wanting to more, it's more comfortable, honestly, to apply more pressure, because then their body's holding you up. So that's why I am more comfortable doing the joint movement piece, but I got a response that went, maybe let's not do too much of that. Okay, that's about as much as I would need to do for now. Nudge, nudge. The workshop's about taping, But I really want to stress how I think this fits especially good in with massage, is because we can do a little bit of something and maybe know it's okay to do even less, because we're going to rely on the tape to do the next part. So I've used it a bit as a way to stop myself from, and even the client, sometimes it turns into like, can you please do more of that? And you go, I don't know, we might tick it up. But it's like, it's feeling a little bit better. Can't we make it feel even more better? It's like, and when they're directly asking you, you sometimes, buckle to peer pressure, right? So I've had to learn, for better or worse, that try to err on the side of caution as much as possible. And something like this lends itself to, it's still another thing. Now, for the sake of doing something different, I'm going to split this and try to be both tendons of bicep brachii. So this is where we could see the two split, and wherever's comfy. You still doing good there? Mm-hmm. Okay. I'm also maybe positioning here, look how it's downhill, maybe encouraging even passive fluid movement with like the bolstering and everything. So I'm going to split this in half, and I'm going to apply, thinking just the shape of bicep brachii, which this is a good time for me to smash away forever as you're learning all this stuff. I'm going to take off deltoid. And look how big that is, how far down that is. So we take that off, and I'm trying to, this is bicep brachii right here, which I can't remove in this model. So you see how it's a ton of muscle right here, becomes more or less one tendon down here. Once we're up here, this kind of last third, but really you can make it simpler. The top half of it splits, okay? And so especially over here, that's the short head of bicep brachii, and right there's coracobrachialis attaching onto the coracoid process of the scapula. I know that's all just Latin and Greek, and I'm sorry, but it's good. So I'm going to try really hard to split it, have one go up and around, and one go right to that point. And then we'll see how messy it is. You have to just kind of try to be, worst case scenario, you mess up, you throw that piece of tape away, and you try it again. So these amazing scissors, we'll see. All right.
I did put lotion on this morning, so I don't know if it's gonna.
It seems okay, yeah.
Okay.
If it's been long enough to truly absorb, we'll call it fine. So here, I'm gonna flip this over and use the grids to help give me a cleaner line. So depending on how OCD you are, you may really want these to be very precise. And these cut like a dream. So about halfway, a little bit less. I'm not gonna worry, well, why not? Let's worry. I'm gonna round these corners, how about it? Round that one out a bit. It's not the end of the world if you have a square edge. It just has a better chance of peeling up. That's all. Yeah. I will say the premium option moving forward for you, Raptor shears. So we'll go here. Now, I have 2 anchors on one end, 1 anchor on the other. So rule 1, pre-tear our anchors. I'm gonna make sure these are bigger. I kind of just start to use my fingers as an approximate. So, you know, first like the proximal part of my first phalange. And then big anchor here. Now we're going to need to put the tissue on tension. I'm going to be slightly brave and I'm not going to remove the pillow. I'm just going to have the elbow go to extension. Does that feel okay-ish? Okay, and supinate. And let me lift you. Let me lift you a little bit out. Is that okay? I just want to get access to the bit of the anterior chest. So, first part, trying to get an anchor. Now, here, the anterior surface of the inner elbow is a sensitive area. I do not tend to tape there just because it's delicate and I'm more prone to skin irritation. Same thing with the skin just behind the knee. I don't tape there. You can some, but just it just gets folded so much. There's going to be more friction. I just suggest no to start. So there's varieties of ways of trying to apply the tape. One way that kind of can be cool is like getting this set, pulling the tape, and using the tape itself as a bit of an anchor to like lay it down. So let me make sure, palpating for bicep, finding the bicep tendon, getting myself set right here. And yep, there we go. So right there, like it did stick, but I lifted it right back up and down. And the benefit we have when we have our two hands instead of just one is I can hold that part down and start applying the rest. So I'm going to start pre-tearing segments to make it cleaner for me. I'm going to pre-tear one tentacle and the other tentacle so that I can apply just this big part first. And I just get that backing off like so. Just be careful, you don't want the tape to itself. That's when it can be more annoying. Now here I'm going to think 50-ish%. What's nice with this brand of tape is I have those hexagons to look at as an objective measurement. So I want one of those big ones to get symmetrical. So this anchor one isn't going to be, so I'm going to look at that big one right there. About symmetrical. And once I have it pulled, then this hand just comes up and smooths it over. So let me actually bring that back up. I wasn't following the muscle well enough. Here we go. Down, down, down. Okay, stop. Now we have to pretend to be its tendons. So tendon 1, I pull the backing up. That's why you keep the backing down, is because it just makes it not a mess. Okay, hold here, and I'm gonna feel over and around. I'm just gonna try to guesstimate. Technical term, guesstimate. You put your finger right on where it tends to get burning and ouchy. Further over. Okay, good, great. Ideally, can I go right over top of that? That'd be great. And then, no tension on anchor. Put a little bit more. I can see I went a little bit past 50%, but I'm okay with that. Now, I'm going to try to do the short head. And I just have to watch out here. Front of the chest, that's the only thing. So sometimes I have to come up and just apply a little bit at a time. You can create an S shape and a U. Ideally, I can come back around, come more over to the front. And then make sure, like in some areas, go around the edges and start just making sure that that's all down. Looking at the skin, no creases or anything where I don't want it. And then here I don't want to just go, like start doing friction on this poor tendonitis. So I'm gonna, if we like how this feels, once we have the hot towels, we can rub that on there. That's where I think the hot towels on this make it a real good game changer. One, it'll feel nice, but then you don't have to be rubbing aggressively on what is usually an ouchy spot, right? So, voila. So what's our time? Try and relax. Okay, perfect. So let's call that lunch.